introduction here for you. So I will give an overview here. He's been the director of the pain management at Scripps Center for Integrative Medicine since 2002, past president of Academy of Integrative Pain Management, and co-editor of Oxford University Press textbook of Integrating Pain Management. In addition to pain management, his strong interest in nutrition, a fellow of the American College of Nutrition, co-director of Natural Supplements and Evidence-Based Update, and now in its 16th year, author of the Herbal Guide, Dietary Supplement Resources for the Clinician. His current clinical and research interests include the use of integrative approaches in the prevention and treatment of chronic disease with a focus on pain, metabolic disease, and stress management. Dr. Bonakdar, thank you so much for presenting, and please, we can move forward.
Sure, Robert. Thank you so much. Can you all hear me okay?
Yes.
Wonderful, and my screen's coming up, I hope. You see the intro slide?
Yes.
Wonderful, wonderful. Well, I know I have a limited amount of time here, about 20 minutes or so, so I'm going to jump right into talking about integrative therapies. Thanks, Dr. Commercy and the ECHO staff for inviting me. It's a topic that's been getting a lot of interest as we're all looking at, best practices in chronic pain. So my disclosures are with the ECHO staff as well. As far as probably the area that we've gotten the most recent attention for the folks on the call have been the American College of Physicians 2017 guideline update, which was last done in 2007. And it had a lot of non-traditional options, integrative options, complementary options, however you want to look at them. And the question is really, why consider these, which ones based on the evidence, and more importantly, how do you incorporate it, especially if they're not typically treatments that you've considered or are familiar with. So those are our basic objectives: rationale, evidence, and incorporation. As far as a few questions, I know the polling system is down, so the next 3 questions are just to sort of get us thinking about how often we need to consider this and what type of therapies we should consider. So the first question, just to kind of have an answer in mind, is how often do low back pain patients use CAM, complementary alternative medicine, or integrative therapies for the care of their chronic low back pain? 10, 20, 40, 80, or 90% of the time based on US national surveys. And next, cortisol levels. When we compare cortisol levels in chronic low back pain patients, how do they compare to those controls without chronic low back pain that are age matched? Are they elevated, decreased, or similar to those controls? And after you have an answer there in mind, which of the following therapies is not included in the 2017 guidelines, the ACP guidelines? Would it be hypnosis, acupuncture, biofeedback, progressive muscle relaxation, or Tai Chi? So we'll come up to all these topics as we go forward, and we'll review the answers. So it's been a very robust year or two in looking at what are non-pharmacological options for pain. I've had the opportunity to work on at least 2 of these articles. Most of these are going to be emailed to you. The staff mentioned in your next email. There is one link to the last one that just got published actually a few days ago. It's a 60-plus page white paper by the consortium that has a link. So that'll get you started, and then some of the brief overview articles should be on your way just for backup reading if there's areas of interest after today's talk. So going back to the ACP guidelines, one of the strong recommendations was for patients with chronic low back pain, as we're familiar now with that recommendation, is to consider non-pharma therapies initially. What does that mean? We want to take a little background about why they said this and what specific ones they chose to include or not include, and what clues there are, because there are not many clues in the actual guidelines, as you wouldn't expect, to how to actually get them into clinic. So let's talk about the why. I'm not going to spend too much time on this. Obviously, this is an area that we're all familiar with. There's been a call for a transformation since 2011 with the IOM report. We know that a unimodal approach is typically benefited in more complex chronic pain patients when there are issues with depression, autonomic dysfunction, when additional therapies are introduced that may approach those. And we know that there's now evidence that if you take a unimodal approach and add some type of integrative therapy, they may have additional benefit. This is one systematic review that was done in 2014 that showed basically when you add things like spinal manipulation, acupuncture to conventional care, you typically have improved pain and function. So the why is something that I think we understand, that we're trying to optimize pain care or have additional options. The one example that I think is sometimes overlooked or kind of minimized in many of these pain scenarios is stress. When we look at the typical autonomic state of the typical pain patients, they are typically hyperaroused, sympathetically driven, and that's been shown in a number of studies. This is just one example that has a nice graphic that shows with chronic back pain, you're typically running on a higher cortisol state, typically until that burns out. But for the most part, this is what's happening when we see that chronic pain patient. They are autonomically overdriven. And we know that that has some specific effects on the autonomic nervous system, including our heart rate variability and other factors that go on to have poor potential outcomes for cardiovascular health, metabolic health, et cetera. So that's an area I think that we sometimes have not necessarily the easiest tools to impart something that can balance out areas that have significant dysfunction that need some attention. And so that answers the first question. I apologize here. I apologize for that interruption there. This is a survey that looked at overall incorporation of integrative therapies, how often. This one looked at overall about 40%. This was actually twice the rate that was done in the NCAM survey. So there's not an absolute correct answer, but at least 20 to 30%, more likely 40 to 50%. And some surveys have found up to 75%. The key point here is probably an average of about half of your patients with chronic back pain or chronic pain in general are going to come in saying something about an interest in complementary therapies or having already tried it. So it's an important question to ask just to see what they're considering or have already tried. In this survey, the most common things attempted were supplements, manipulation, and massage. Going to what treatments may have the most evidence, because in many cases, patients' choices may not be ones that are actually the ones that are most likely to help their specific condition, to try to guide them as to the best of our ability. I'm going to give you some overview quickly. There's also a lot of resources at the end in the appendix, which I don't have time to go into, but hopefully will give you some opportunities to provide some guidance for your patients. So on the left are the therapies that have slightly stronger evidence. On the right are also ones that were included in the ACP guidelines. We're going to try to go through these. Again, hypnosis was not included in this overview as a question to the answer to one of those questions. So going through some of the specific ones which we may be less familiar with, CBT, I think most folks, cognitive behavioral therapy, we're very familiar with its benefit, exercise as well. I'm going to go into some of the areas that we may have less experience with. So progressive muscle relaxation is actually a very simple technique, has been around for a long time. There is a script at the very end of your slides that you will get that kind of takes people through it, and there are actually online versions of it for free that your pain patients can utilize at home. What it is basically is a step-by-step guide that takes patients through a series of contraction and relaxation exercises from head to toe, basically accompanied by deep diaphragmatic breathing. We know doing this in a chronic low back pain, which is sort of the focus of the guidelines, is the condition I chose, seems to have benefit both for pain and, again, equally important in a lot of these patients is their autonomic hyper state or stress level. So this has a simple ability over a month of doing it on a regular basis, about 5 to 10 minutes a day, of imparting some benefit. So again, something simple to start with, especially with not having a lot of resources. If you do have some additional resources, biofeedback can be seen as a more kind of high-tech approach to incorporate some of these measures, where you might be getting a sensor on somebody's muscle that may be having issues with hypertonicity, or you're looking at heart rate variability, which is an easy measure of heart rate variability and autonomic hypersensitivity. And once you have that, you go through some of the same techniques of relaxation to see if there is an impact. What this allows the patient to see in real time on the screen is how their body may react to a specific relaxation technique better than maybe another one. So it allows them to go home and focus on ones that they've seen actually have benefit in real time in the clinic. Some of these units start at about $100 if you're looking for something simple like heart math, and there's obviously more sophisticated ones. But again, nothing that can't be done with minimal incorporation. Not too much education is needed to get up and started in the clinic. Tai Chi is another one that I'm going to mention briefly. There's been now a number of studies looking at its benefit in low back pain. I describe Tai Chi and yoga as types of mindful exercise. So one of the sort of stealth approaches that they have, that in addition to exercise, and actually Tai Chi, if done appropriately, is done in China as part of cardiac rehab. So it can have a moderate aerobic ability to it or benefit, but really what you're doing in addition to the actual calisthenics is incorporating awareness of posture, awareness of balance, awareness of breath, which kind of is a good balance with the actual movement. It's been shown to be highly acceptable, and a number of studies, including this one, showed benefit in reducing aspects of chronic pain. There was a combination of 3 recent studies, which again showed a pretty high standard reduction in both pain and improvement in overall functioning, actually better in low back pain than in osteoarthritis, which Tai Chi again is endorsed by Arthritis Foundation as an approach as well for arthritis related pain. But in low back pain, especially folks who have any level of fear avoidance or difficulty with exercise, I find Tai Chi is a nice thing to start with a good teacher that deals with folks with pain to kind of get them on, kind of a gentle journey towards more activity and exercise. Yoga, many of us are familiar with this. It's been recently shown in a number of studies, many more than Tai Chi, to have some benefit. The standard mirror difference is actually not as high as Tai Chi, but moderate, and can have benefit, and does have evidence as well in reducing some of the autonomic hyperarousal within a month of use. So what I like about yoga is it can be used in any population. This is Rob Saper. Some of you may know him. He works in the Boston area, did a very elegant study using it in yoga in predominantly non-English speaking population, had no experience with yoga. So it doesn't have to be done in a certain population. It can be used in any setting with a very basic movement overview, and does have some benefit in reducing pain as well as other pain treatments. High satisfaction rate along with Tai Chi. Acupuncture and aspects of treatment related to acupuncture can also have benefit in a number of studies. There's obviously a lot of discussion of what is the most appropriate type of acupuncture, placebo controls, but for the most part in systematic reviews, even in those that do have a sham control, there is moderate reduction in pain. And this is a meta-analysis looking at those that did have sham controls. What I find most effective personally in my clinic tends to be, I'm a family physician by training, so I still see some folks that have other medical issues that we're seeing, and so I might not have a lot of time to do acupuncture, full scope acupuncture. Sorry about that. So I use a lot of auricular therapy, which allows you to do ear therapy. In some cases, may take very few moments out of the clinic. You may put them in and continue with the treatment. So it's something that you or your staff can get trained in relatively quickly if you don't have a full scope acupuncturist available to you. And this has also been used in the post-op setting. Massage is something that we see sometimes as more of a luxury. It does actually have some benefit that's long-acting or cumulative if there's enough treatments. In this case, they were treated for 12 weeks, continue to have benefit at 24 weeks, done in a primary care setting in low back pain. So again, it has to do with the practitioner and how adept they are at dealing with chronic pain. using more acupressure or deep tissue to work on some of the areas of trigger points. So diet and supplements, this was not covered in the ACB guidelines, but I think it's an area that we all agree that many of our patients, especially with chronic pain, overlaying with obesity, chronic inflammation, could benefit from an approach that they're using every day anyway. So we've done some work with the Academy of Integrative Pain Management, which Dr. Mercy and some of the other folks, I believe, are familiar with the Academy. So we put together a 6-hour course that we presented last year, and now we are going to repeat that this year, which had benefit in taking practitioners who are seeing folks with pain and making it more comfortable to give a specific nutritional prescription of how to incorporate anti-inflammatory foods and potentially cost-effective supplements, knowing again that some of these folks may have nutrient depletion or deficiency or insufficiency. One quick example, I'm just going to give you one for sake of time. This was a study taking 4,000 units of vitamin D and giving it to patients on various analgesics, most of them on opioids, and finding that the vitamin D, in addition to getting them to moderate to adequate levels, many of these folks, as the literature shows, are insufficient or deficient, had benefit in reducing pain moderately. And there was some mechanistic appreciation here that vitamin D did have an anti-inflammatory effect. We know that aspects of nutrition, obviously, in folks that are depleted or already inflamed, may have an impact that may be stronger than somebody that's, community dwelling that doesn't have a lot of pain or inflammation. So I take a special interest in talking about vitamin D, magnesium, and being nutrient replete as best I can. So finally, how do you incorporate this? Again, there are many different approaches in different community settings. Some communities have a lot of access to therapists, others do not. Cost is obviously an issue. I'm going to just focus on some therapeutics using a group medical visit. Some of you are very familiar with this. If you're not, it's basically taking an expanded time frame, usually 1.5 to 2 hours, where the physician is aided by other staff. It could be a dietitian, it could be a psychologist, it could be a body worker who comes in and for that week may do an educational or self-care session. And this is an example of a rural clinic that attempted to put a very low-cost approach in, where each week they would have something from stretching or Tai Chi, somebody else in the community who would come in, and with the approach, with the thought that this may help reduce opioid management or opioid medication. It can be used free of that, so that's not the ultimate goal, but in many cases to bolster patients' self-care approaches, which in some cases there's not a lot of time to do in an individual setting. Typically done 8 to 12 patients at once. They obviously have a consent that they are okay doing this in a group, but for the most part also builds a lot of rapport and peer support, which sometimes can be quite important in folks and improving their function and outlook. So there's one reference for you. You can also take a specific component. So you may not have the ability to have an acupuncturist to treat single patients or have insurance coverage. This is a Cleveland clinic and a lot of community acupuncturists where the treatment can be done for $15 or $20. We have that in our community, and it's done. This is Jamie Stark at Cleveland Clinic, where she's treating, in some cases, 12 to 18 patients at once, and they stay there in some cases for a period of time, and she's able to do that in rotation. Additional resources. So Jeff Geller is one of the kind of grandfathers of this technique. Paula Gardner, I'll reference some of her resources as well, but there's a toolkit that's available if folks are not familiar with that. And again, the group support that's often created in this is one of the more important things in addition to the therapeutics. As far as resources, I just wanted to mention a few quick things. The AIPM conference in November does have sessions on group medical visits and some of the therapies that I talked about, in addition to a number of sessions on conventional care, medication management, et cetera. We're trying to come up with the best case scenario of having resources available to our patients. And to conclude, before just doing a snapshot of the resources, is we need obviously to look at new options to transform some of the areas that in pain care can be optimized. Just like with conventional care, there's no complementary or integrative or non-pharma options that are magic bullets. And when you're talking to patients about that, many of these do take a series of accumulative treatments and daily incorporation, especially the mindfulness exercises and exercises for them to really impact their pain. And more importantly, the comorbidities, whether they're stress, depression, low energy, etc. Basic techniques are there, such as the guided progressive relaxation and breathing exercises, to more advanced techniques such as the biofeedback. And models of care, such as the group medical visits, are making that more allowable in various communities and clinics. And finally, opening the conversation is key, because I think when I'm in my clinic and talking to other clinicians, it's not until we really ask, what are all the things you're considering? And until that point, then we don't really know what patients are considering until we ask that question. And sometimes we agree with what they're thinking about. In many cases, we're kind of astonished or shocked about what they have tried for their pain. But it begins a conversation. Hopefully we can use that to gain trust and guide them towards things that are more evidence-based. And then finally, you have a whole bunch of things, resources, links, videos that I think can be start a conversation and educational process for your patients. So I'm going to end there.